So as a dietitian, I was working in my clinic, and a patient came to see me after a 5-year gap, and when I wrote on the record card, I noticed my handwriting was a lot smaller than it had been the 5 years prior. When I tried to make my writing bigger, I couldn't. I thought, that's very strange. Got asked to be referred to a neurologist, and he thought it was very unlikely that I had Parkinson's because I was very healthy, I was pregnant. The only other symptom I had was this sort of aching arm. So I was put through a brain scan and a trapped nerve test, which subsequently I learned a lot of people with Parkinson's are put through. A lot of expense, but the reason I couldn't have a DAT scan, which was mentioned before, was because I was pregnant. So I had to wait until my daughter was born and finished breastfeeding before I could have a DAT scan, which confirmed that I did indeed have young onset Parkinson's. So my daughter was born. We were absolutely thrilled. It had taken us a long while to have her, but unfortunately was born with me having Parkinson's disease. So I suppose this started my journey in looking at sex and gender, because the image I saw of Parkinson's was that of an older white male. So just to kind of give the backdrop in terms of sex and gender, what the definition is. So sex is basically the biological differences in terms of our chromosomes. And gender is really the kind of social construct of how we behave in society. And there's a continuous interaction between sex and gender that determines our health outcomes. But women are more likely than men to be subjected to impacts of health-related disparities. That is, forces above the skin, so more gender issues. So why should we care? Well, the reality is that 4 out of 10 people with Parkinson's around the world living with Parkinson's are women. And actually that number might be actually higher in some cases. And just another interesting fact is up to 30% of people with Parkinson's are under the age of 60. That's more than the total number of people with MS in the world. But a lot of people don't know that. So I'm going to look at, there was a talk earlier on about sex differences in prevalence and incidence, so I'm going to look at the sex differences side of things. So I actually took this information from the Parkinsonsaustralia report that was mentioned, and it shows here that the incidence and prevalence is indeed higher in men than it is women. This also broke it down in terms of the age, which I thought was interesting to see as well. So if you look at the 80 plus, women actually have a higher prevalence than men. And that is generally considered because women live longer than men. But that's an important point to take into account in terms of care for women. So this was quite interesting. This was the Australian Pharmaceutical Benefits Scheme data. Now, I'm not an epidemiologist or that, but it was quite interesting. It was actually an Australian physiotherapist researcher who emailed me with this data, that actually in this data, 54% of women actually were seen to have Parkinson's, and only 46% men. I don't know why that was, and again, those who are more expert in this area might be able to give answers to that. But interesting in terms of the breakdown of age, I thought was very interesting. That actually, 10% were under 55 and 24% were under 50 or within the 55 to 69 gap. So that sort of tallies a little bit with the 30% under the age of 60. So other reasons why we should care about looking at sex and gender is the incidence generally is higher in men, it's lower in women. Disease progression is faster in men, slower in women. Men have a shorter lifespan with Parkinson's, women have a longer. Deaths from Parkinson's, higher absolute number in men, lower in women. And actually, in terms of years of life lost between 2003 and 2023 was shown to be twice that of women in men. So the reality is for men, they often delay seeking support. They have more severe motor symptoms and they have more rapid progression and a higher incidence, and they die sooner. So we need to, it's not just about the women, it's about the men in the audience here as well, as what answers do we have potentially that can help both sexes. So I'm going to look at the impact of hormones in terms of progression, PD risk and progression. So, and there's a lot of information on this, but I think hopefully you'll be quite interested in it. So men's brains age faster than women, which may relate to worse memory and movement problems. They also, in terms of testosterone, higher testosterone levels in men is linked to more damage in the brain, including protein buildup and brain shrinkage. But actually there's not enough evidence yet to actually say, give someone testosterone and that's going to solve the problem. But I think what it says is we need more research. Low testosterone was significantly correlated with apathy independent of disease severity. And very low testosterone can be unfavorable for the well-being of men with Parkinson's. But we need, again, more evidence about, is this a potential treatment path? Also, in terms of men, they also have hormones that women have, which is called gonadotrophins, LH and FSH. And they might mediate age-dependent cognitive decline and the buildup of amyloid, which is related to Alzheimer's in men. So the hormones are not just impacting women, they're also impacting men. And also very interesting, men obviously have estrogen as well, but also estrogen may be protective in men with Parkinson's. So men, there was a study done quite recently that showed that men who had higher levels of estrogen in their body had milder motor impairment, lesser fluctuations, and actually, didn't have it for as long as those who had lower amounts. And as they progressed in their disease, their estrogen levels dropped. So there's something there in terms of estrogen with men. In terms of women who experience menopause at an earlier age may be a higher risk of developing Parkinson's. And we know women who have, oophorectomies have a higher risk of Parkinson's, but that risk basically disappears, a bit like IBD and taking anti-TNF. The risk disappears when they're put on HRT. Women who have more years of natural fertility before menopause have milder symptoms and need less Parkinson's medication. Lower estrogen levels in women with early onset Parkinson's was associated with more severe motor complications. This is quite interesting because dystonia, I know with a lot of women, dystonia is a big problem. And actually there was a study showing that lower testosterone levels in women with early onset Parkinson's was correlated with increased risks of dystonia episodes. Women who also have more, so when you go through the menopause, you lose your estrogen from your ovaries, but actually the body has estrogen receptors all over our bodies, and in particular in fat cells. And so the body kind of knows that we need to have a certain amount of estrogen to kind of keep us going. So basically women who have more of that residual estrogen in their body after menopause tend to have less severe motor symptoms. And women on the other side who have higher levels of testosterone and another hormone, the FSH, is linked to worse thinking and memory. And lastly, hormone replacement therapy, you'd say, well, that's the obvious answer, but we need more research about that. I'm going to just talk about HRT now. So you can see in terms of hormones, there's a lot there that we need to look at in terms of Parkinson's. So in terms of HRT, impact in general, HRT is shown to basically increase dopamine synthesis, upregulates dopamine receptors, decreases the breakdown of dopamine. It helps to improve memory function. It protects the cognitive function. It influences emotional and motivational behaviors and decreases impulse behaviors. And also progesterone may promote sleepiness and reduce anxiety. And it appears to actually increase the respiratory drive. It helps to reduce sleep apnea, which is quite common in Parkinson's. So that's, in general, the benefits of HRT. In terms of the impact of Parkinson's, it may be neuroprotective. So that's the reason why women sometimes tend to be sort of diagnosed postmenopausally, is because basically you're losing your estrogen, which is neuroprotective. It may be that it improves dopamine neurotransmission. It can also have an anti-inflammatory effect. So we know estrogen is basically a natural anti-inflammatory hormone. And it can also modulate other neurotransmitter systems like serotonin. So just this second last line here, talk about MPA. That is basically a synthetic version. So there's a lot of scaremongering about HRT being linked to Alzheimer's risk. But when they looked at that study, it was in women over 60, and they used a synthetic form, this MPA, which actually is not good for the brain. So the type of HRT that's used now is a natural form. So then I'm just going to go on in terms of the impact of hormones and Parkinson's symptoms. So this is kind of one of the main areas that sort of started me off researching this, is that I noticed when I went back to menstruating, and my Parkinson's symptoms were worse the week before my menstrual bleed. And I noticed when I went to the World Parkinson's Congress, I met lots of young onset women there, that they were reporting a similar thing. So I thought, I'm a scientist by heart. I said, okay, I'm going to do a survey and see what's going on. And we surveyed 240 women around the world, and basically 86% of them reported the same phenomenon, that their symptoms were worse before their menstrual bleed. 49% during their menstrual bleed, and then 9% after that. So I was kind of thinking, well, what's going on there? And the estrogen is part of that story. But the other thing is, from that survey, we had 2 webinars, one with the Cure Parkinson's Trust, one with PMD Alliance in the States. We had over 600 women attend both of them, and women were, a lot of issues came up in terms around their hormone, their menstrual cycle, the perimenopause, postmenopause. Women were worried about dementia, access to care. There was lots of issues that came up. So we wrote a paper called The Unmet Needs of Women with Parkinson's Disease. And what we did is we outlined the different hormonal stages of a woman's life and what are some of the things that need to be considered. And this is not really considered in terms of research or care at the moment as much, I think, as it should be. So we also, in terms of that survey we did, was just a survey monkey that I sent out, but this then was validated by other surveys. So the Michael J. Fox Insight platform, we've done several surveys on that platform, and it showed that 44% of women indicated that their medication was less effective the week prior to their menses and 30% during. And then we had a research group in Spain called the Valhebron group, who again showed that women reported 38% less effectiveness of their medication the week before the menstrual bleed. So I'm just going to show you here in terms of, so what do we do about that? So we know out there at the moment that women with Parkinson's, if they have this problem, they might be given extra levodopa because the fact that the medication is not working as effectively, you give them more, and that works for some people. Then in other women, they might be given the oral contraceptive pill, or if they're on the oral contraceptive pill, they stop the week break. So when you have a week break when you're on the OCP, it basically means your estrogen drops. So if you stop that, then that could potentially help the symptom fluctuations getting worse the week before your menstrual bleed. And that seems to anecdotally work for some women as well. But we don't have enough sort of evidence to kind of say, this is a clinical guideline, this is what you should do. So we need more evidence. But this is just an example from a case study, done a case of one by a researcher, and this just shows you here a woman who had, this is her walking before she had continuous estrogen therapy. So I don't know it's going to go. Oh. How do I play the video? Do I have to do something? Oh, there we go. So this is the young woman walking on the beach. And then this is after continuous estrogen therapy 4 hours later. So it seems in that case that it's quite a clear-cut improvement. Not sure exactly what's going on, but I think it's something that we need to investigate more. So then in terms of, we talked about the menstrual side of things, but in terms of menopause. So I basically worked with a neurologist in the UK who was doing a sort of analysis of her cohort of women. And she did this sort of image, which I think is a very good depiction of the non-motor symptoms of Parkinson's really mimic the menopausal symptoms hugely. And this is probably one of the problems with women maybe getting diagnosed later, is because they're thought to be going through the menopause, when in some cases it is actually Parkinson's that they're experiencing. And I suppose the question is it the menopause that's triggering the Parkinson's, or is it just that we're going through menopause at the same time and the symptoms just worsen our symptoms? It's like an additive effect. So in the survey that I'd done before, we also asked women about the impact of the peri or menopause on their Parkinson's symptoms. So a small percentage, 1.9, said it improved, but actually 30% said that their Parkinson's symptoms worsened as they were going through the perimenopause into menopause. And 65% said they weren't sure, which I'm not entirely surprised with, because it's such a confusing time to know which is which. And then in terms of comparing pre versus post-menopause, we see that there are certain things that get worse. So the likes of constipation, this is by the Valhebron group, and urinary urgency get much worse as you go through the different hormonal stages. And in a study done by Bas Bloom's team, a survey, they showed that 2/3 of women report an increase of their symptom severity post-menopause to pre-menopause. In the survey we did of the 240 women, we asked the question, did neurologists talk to you about the impact of hormones and Parkinson's? Did they adjust their medication? Did they talk about hormones, suggest HRT? And the resounding answer was 90% of women said no, they didn't engage on this at all. So I suppose this is what led me, as a person with Parkinson's, wanted to, and it was out of the paper that we did on the unmet needs of women with Parkinson's, we wanted to give women a tool that would enable them to prove that they're experiencing what they're experiencing, which I know is a bit nuts, but that's kind of how science works. You have to prove it to be able to get the care. So I developed an app called the My Moves Matter app, which allows women to track their Parkinson's symptoms across their menstrual cycle and other stages like the perimenopause and menopause. And basically we're just finishing up a pilot trial that we did with University College Cork. So we have 500 women who have done the survey part. We have 100 women who've tracked using the app, and it's global as well. So it'll be really interesting to see what the results of that are. And then also we have another pilot that just started in France in 4 neurological centres, specifically looking at young onset women. So they're going to have a treatment arm. They're going to basically track using the My Moves Matter app. They're also going to have a PD monitor, which is a connectable, so they can actually see does the data that's collected through patient-reported outcomes marry what's actually shown on the PD monitor. And then they're going to do an intervention arm. And I don't know what that's going to be, because it's going to be up to the neurologist and the patient, the woman, what they're going to choose to help them. So very excited about that, because Professor Elena Morrow, who is the president of the European Academy of Neurology, is the lead PI in that. So then in terms of differences in Parkinson's symptom presentation. So this is from our paper as well. So this shows you, hopefully you can see there, it comes out well, the difference between the symptoms in men and women. So for example, women tend to be more tremor dominant, suffer from more facial masking, and that actually can have a real issue for women, because women are expected to smile. Do you ever been told, go on love, give us a smile? You never hear that said to a man. And the reality is, I remember my son saying to me a number of years before I was diagnosed, he said, Mum, you don't smile as much anymore. I was like, it's only on reflection, I was going, oh my God. So it's actually a really important thing for women in terms of, it affects their relationships, family and friends and beyond. Women also suffer from more levodopa-induced dyskinesia, which I'm going to go into, and restless leg syndrome. In terms of non-motor symptoms, mood, sleep disturbances, anxiety, depression, fatigue, pain, urogenital symptoms. But on the flip side, they have less cognitive impairment, less hallucinations, less gastro symptoms, and less sexual dysfunction. But lots of psychosocial issues, and that's really to do with the gender side of things. Self-reported disability, quality of life is worse, negative, destructive self-image, feeling of loss of femininity, impaired sexual intimacy, feeling of not being heard. That's a huge one for women with Parkinson's, and downplaying their symptoms. So it's shown that women, if they're basically dismissed 1 or 2 times, they will not go back to that doctor, and that's a big problem. And women tend to have less social support. So women always tend to get to their appointments with their husbands, but husbands don't tend to maybe go as much with the women. And also because they live longer, they possibly may not going to have a partner to go with them, so this is also an issue. So really, this is about women not being small men. So this is also showing in terms of data that we aggregated data in the My Moves Matter app. So it's open to men and women to use, it's free. So we've got 70% women, 30% men on average, and we aggregated the anonymous data and looked at the top 10 symptoms. So you'll see here in terms of, on the women, dyskinesia accounts for 9%. It doesn't even appear on the men's top 10 symptoms. And also you'll see the profile is quite different. So the men's symptoms I would sort of classify as being more disabling in terms of swallow issues, voice issues, loss of smell, loss of balance. The women's are more sort of bradykinesia, fatigue, difficulty sleeping, muscle and joint pains. And actually interesting in terms of muscle and joint pains, just to kind of show that estrogen is anti-inflammatory. So frozen shoulder is actually much more prevalent in women than it is men. And that is, it gets worse. It's actually almost seen as, if you talk to gynecologists, it's actually a condition of menopause. And I think that's probably why women suffer from a lot of pain with Parkinson's. So the other thing is women suffer from more wear off earlier and have more fluctuations than men. But no one's actually looking at why. In terms of response to medication, so there was no randomized controlled trials of levodopa for looking at men and women, because it basically was before the FDA said you have to look at the difference. And there has been a paper written, I can't think of the gentleman now, a pharmacologist in the UK, that more or less alludes to the fact that if levodopa was produced today, it possibly wouldn't pass the mustard in terms of, it's the RCT looking at men and women. So women tend to suffer from more side effects from levodopa because we actually absorb more of it. So research has shown that potentially women need 25% less. And I always thought it was a bit odd that I got 3 doses of levodopa a day when a man who was like 6 foot and 100 kg got the same. The other thing then is that women have 25% less COMT enzyme. And I actually was put on opicapone because I was sort of noticing I was wearing off a bit, sooner than usual. They put me on opicapone and they said, okay, we need to reduce your levodopa a bit. But I noticed I was getting this sort of dyskinesia and I was like, okay, I don't like this. But they couldn't, if they reduced me any lower on levodopa, it actually had no benefit at all. And the problem is that you've only 1 dose of opicapone and you can't break it in half because it's a capsule. And the study was done, I don't know, but probably primarily in men. So it's shown in research that women are not included in the phase 1 and 2 stages of clinical trials, and that's when you find out about adverse events. So by the time it gets to phase 3 and 4 and it's developed, it's too late to do anything about the drug side effects. So this is not just a problem for women and Parkinson's. So we actually need our researchers to be more personalised about the care for both men and women. And this just, often it's said that women, dyskinesia is not a troublesome, symptom. Well, I would counter that because I know a lot of young onset women who are really debilitated by dyskinesia. So you see this here, I've suffered dyskinesia since I started taking levodopa for my YOPD last year, and I've lost 6 kgs of weight. So that's basically because of the excess movement. It burns a lot of energy. Another woman, I suffered dyskinesia, it greatly affects my daily life, affects my head and upper body, and yes, absolutely wears me out. It makes you lose confidence. It gets worse when someone talks to me, and I'd say it's probably my worst Parky symptom. So it is not a non-troublesome symptom. And this was a study done quite recently from Japan that showed that nearly 70% of patients with dyskinesia were women. The risk of dyskinesia was 2.6 times greater in females. So the other thing then in terms of differences, genetic differences. So there's a gene called the LARC gene, and there's a specific version of that, which is on the screen there, which is associated with being predominantly female. It's associated with higher rates of early onset and family history, less hyposmia, higher levodopa dose, though they respond to levodopa well, but they get more dyskinesia, they have more fluctuations, less depression, and ultimately have a better quality of life. In terms of, on the male side, men who have the GBA1 carriers, it's basically shown to accelerate cognitive decline. So this particular paper said that focusing on the influence of hormones could lead to better understanding of the sex variability in Parkinson's, as well as reveal new therapeutic avenues or preventative strategies. So then I'm just going to go on in terms of differences in access to treatment. So this again was the paper that the Australian physio researcher sent me, which looked at the prevalence being higher in women in that cohort. But even though women were accounted for a higher amount of the cohort, they actually accounted for the lower percentage of women who got add-on therapy. So this paper looked at when they started levodopa, when did they start adding on, an agonist or, other treatments. So women tended to be longer before they got those add-ons. And the question is that because women's disease progression is more mild? I don't know. But also it's showed that in tendency to add on additional therapies for Parkinson's at lower levodopa doses was in young onset in women. So in other words, I kind of wonder, in those women that they do start earlier, is it because they get more dyskinesias and so they need more treatment earlier? I don't know. There's a lot of questions and not many answers to my mind. Also in terms of device-aided therapy, there's a whole day yesterday in terms of device-aided therapy, which is basically DBS. It's your progeodopa pumps, or I think there's another name for it here. Things like your Lessig pump, your duodopa, all those kind of different therapies. So basically, in a very recent study in 2020, this year, younger patients are 2 to 3 times more likely to receive these advanced therapies compared to older people. You're less likely to receive these therapies when you're over 85, female or black. If you have a lower education and poor English, less likely to initiate these therapies. And if you're married, you are 4 times more likely to get one of these enteral suspensions than if you. I can understand that because often you need a sort of care person to help you actually, replace the enteral suspension, etc. In terms of DBS, so there's less access to DBS for women than men. They seem to be referred less for DBS, and there seems to be a bias within the neurologists in terms of referring women. Women get less support to help them make the decision around going for DBS. Also, women have a greater caregiving burden, so they have a big decision to make to get open brain surgery, say if they've got older parents that they're looking after or kids that they're looking after. So they have a different, and this is where gender comes in, they have a different decision-making process. And it's shown in a recent paper that women need more time. They need to have that backwards and forwards to make that big decision because they have a greater fear of surgery. So it shows that women, when they actually do get referred for surgery, turn it down more often than men. So is it because we're not giving women the right information, we're not answering their questions? Again, we need to find out more. In terms of differences in research participation, so this basically, again, with infusion therapies, women with advanced Parkinson's were underrepresented. And most of the trials that they looked at overlooked sex-based biological differences that can impact clinical and functional outcomes, and raising concerns about generalizing the findings from studies that are more prevalent with men than what's happening in the real world. And actually, just as a person with young onset Parkinsons and a dietitian and talking to a lot of people with Parkinson's, I don't hear very many. I hear a lot of people been pointed down the DBS route. I don't hear as many going for the sort of pump options before. And I don't know why that is. And I think there should be more focus on all of the DAT therapies. Also, in terms of disparities in enrollment in Parkinson's clinical trials, so this is a big sort of meta-analysis, looked at 328 trials, and the percentage of women was 38.8. So it's not too far off the 40%, but actually there is potential that in some countries, so the likes of Poland, the likes of Japan, it's actually higher in women than it is men. Don't know why. But in terms of representation, racial and ethnic minorities are underrepresented. So disease enrollment and equitable healthcare across access is needed to further Parkinson's knowledge, treatment and informed policy decisions to really apply to everybody with Parkinson's. And I suppose this is just a great image. So as I say, the picture of Parkinson's has always been that sort of stooped, old white man. And I personally feel it's done a disservice to research and care because that's the way that we're been treated. And it's the same for young onset men. They present differently to later onset men. And it's not to disparage those of us who are older, and because that's a very important cohort that needs to be treated too. But I think there's answers in actually looking at the research from a more equitable approach. So this was basically new images that was drawn up by Barbara Salzberg, who's a Canadian woman, to sort of depict. And I know there were some people who were a bit upset about it because it sort of shows the progression of Parkinson's. But I think this was really designed for the research industry to really think differently about their approach to their research. So I'm just going to play here. Do you play it for me? Do I have to press it or? Oh, there you go. It's not playing.
Illustrated these 5 stages of Parkinson's as represented by young women with different ethnicities. Because as women, we don't often see ourselves reflected in the drawings that are associated with the people who have Parkinson's. It seems to be white, older men. So our time has come, and that's why I illustrated it. Hopefully we'll change stereotypes, and because about 40% of people who have Parkinson's are women. And unfortunately, more and more younger women and men are getting this disease. So if you're aware, then you can get help. So that's why I made this artwork. Happy International Women's Day. Ms. Barbara Salzberg.
So just in terms of finishing off, I'm going to just focus on lifestyle factors, but I've only focused on one thing because I was conscious of time. And I'm doing a session sort of around diet tomorrow. But in terms of pesticides, obviously this is a big area. People exposed to pesticides, especially on farms, have a higher risk of developing Parkinson's. Men often work in jobs involving spraying pesticides, which may partly account for the higher rates in men in some regions. In some regions I mentioned, Japan and Poland, more women work in farms, so is that the reason why it's higher in women? Body fat and toxins, women have more body fat, which may store pesticides and release it over time. There's also changes in pregnancy, breastfeeding, menopause may affect how women react to pesticides. And pesticides may interact with genes differently in men and women, but we need more research in that. And just in terms of geographic clusters in Australia, I just noticed this in one of the reports, and I don't know if these areas have a higher level of farming use of pesticides or what, but it seemed to be that they were high cluster areas for Parkinson's. So there was a paper that came out very recently talking about Parkinson's in terms of sexual dimorphism. So what does that mean? Basically means that we basically, diverge as we go along our sort of, life stage. And that is impacted by, lifestyle behaviors, it's developed by hormones, by genes, etc. So there are differences that are making a difference to how Parkinson's is developing and being treated. And literally just, I saw a paper literally this morning in terms of inflammation that showed that men had higher peripheral inflammation, which was associated with worse clinical features and a greater central alpha-synuclein burden. In terms of women, they had lower peripheral inflammation, milder clinical features, and lower central synucleinopathy. So basically, systemic inflammation clusters with sex, hormones, and clinical features, and central synucleinopathy in Parkinson's supports the relevance of immunity in Parkinson's disease. And actually, what's interesting is, in terms of IBD, it's higher prevalence in women. In terms of thyroid disease, high prevalence in women, because basically we tend to have more inflammatory conditions, and they get higher postmenopausal because estrogen is an anti-inflammatory. So why bother looking at sex differences? Well, the first thing is understanding these differences can lead to more tailored and effective treatments. Underrepresentation leads to incomplete understanding of the disease and adverse medication side effects. Hormonal influence, understanding hormones can help everyone. Lifestyle factors, studying both sexes can provide insights into these interactions. Gene regulation can help identify these sex-specific patterns and their implications for disease development. An improved study design can enhance the accuracy and relevance of research findings, leading to better therapeutic strategies. And I'm just going to mention this last thing, and I know I've gone over, but very exciting. I went to a conference in Vienna, and I met this woman, Roberta Brinton, who is an amazing researcher in Alzheimer's, and she's actually looking at Parkinson's. Now, a very small study. She did an open-label study of a metabolite called allopregnanolone, which is basically a progesterone metabolite. And basically, with a drug treatment they did for this allo, they gave for 12 weeks. And what was really interesting is there were mainly men that were actually the participants. And she showed us the DAT scans. They improved. And also, 4 out of the 9 reduced from Hoehn-Yahr 2 to 1. And everyone showed improvement in their symptoms. So I suppose I want to end on this to show that it's not just about women. It's about finding differences that actually could benefit everybody. So thanks very much.